Hi, Dr. Kandwala from Advanced Urogynecology. We shall talk about pelvic organ prolapse management. We just talked about what prolapse is, why does it happen, what are the different types of prolapse, how to do a proper examination for prolapse, what are the different complaints that a woman may have with prolapse, what can go wrong if the prolapse is not corrected. So what are the complications of just having that prolapse be there? And now let's talk about management and how do you manage this. So there are three options. One is expectant, pessary, surgical management. Expectant, that means just observe and follow up. So here the most important thing is, let's say your doctor sends you to me because you have a vaginal bulge and you did not really know about it. And when I examine you, yeah, it is just coming to the vaginal opening, but you're emptying your bladder well, you have no complaints as such, you're not really bothered by this thing. So I'll examine you and say, let's just watch it, or maybe we can do pelvic floor exercises and pelvic floor therapy. And you can be followed up either 6 monthly or yearly, and we can just watch it. You can watch it at home, I can watch it periodically. So no intervention needs to be done. Pelvic floor therapy is where you can tighten the pelvic muscles and relax the bladder at the same time, try to prevent these organs from coming down, because as I mentioned in the initial slide, muscles are very important, ligaments are very important, and our physical therapist will work with you to keep the pelvic muscles nicely engaged, and you will be doing this on a periodic basis. So do not discount the value of this, and I'll talk to you absolutely about doing this after we have corrected the bulge, and especially if you needed surgical correction, because then, like knee replacement, you cannot have a knee replacement and go home. Following knee replacement, you need physical rehabilitation. Same thing here, you need PT after a surgical intervention, or even if it's a mild prolapse, and as I mentioned, after surgery. Pessaries, I personally don't like pessaries, and I'll tell you why. But the pessary I use is just the ring pessary. It doesn't really correct the problem, it just hides the problem. So it is done in the office. It's ideally placed in women who are not good to undergo surgery. They have bad heart disease or something like that, high risk for surgery. They're the ideal people for this. Or if they're waiting to undergo a surgical procedure that I may replace it in, or they're pregnant and the uterus is just coming down in the first trimester, we put a pessary in until it becomes a belly organ, and then the prolapse disappears as the uterus goes inside. So in certain select cases, it makes sense, but in most cases, it has its own problems, where you have to come every time, frequently, lifelong, for every 2 to 3 months to the doctor. And that may not be possible at certain age. And you may not be able to come or drive yourself to a doctor's office, and then you have to take favors. Every 4 times a month, you've just got to come to clean the pessary. If you don't, then it can cause problems. The pessary itself, even if it's there, can cause discomfort, discharge that could be smelly, spotting, or bleeding. And sexual function is difficult to do with this thing in place. And it is difficult for the pessary to sometimes stay in, depending upon the prolapse. And remember, just like occult incontinence, you put it in, the urethra straightens up, and there could be urine leakage. I've seen bad complications with the pessary, where it actually cut through the vagina into the rectum. So complications and major complications can happen with the pessary. Typically what we see is discharge, irritation and bleeding, and rarely do I see what I just told you. So, but this itself, the fact that it is causing some discomfort or this discharge and bleeding, most women do not want to deal with this because they have to deal with it for the rest of their lives. And if you ever take it out, the bulge is coming right back. It's not correcting it, it's simply hiding it. So they're not free of complications, ideally suited for high-risk patients. From a surgical standpoint, we have two options mainly: the native tissue using your tissue or mesh augmentation procedure. Some of them are associated with a hysterectomy or uterine preservation. I personally preserve the uterus. I do not believe in taking it out. And then one other procedure is where we close the vagina, and I'll discuss that in a separate video. In women who are not sexually active, I just close the vagina. The native tissue, that means using your own tissue, is using your tissue of what's called the fascia or the muscularis between the vagina and the bladder in the front, vagina and the rectum at the back. Most cases would need a hysterectomy. But the problem is there's a very high risk of recurrence. That means it fails in about 60% of the time. So it's almost like tossing a coin. Is it going to hold or not? Especially if there's a large prolapse and recurrent prolapse, then the risk is even higher. Mesh augmentation is typically done for those large prolapses, especially of the bladder, especially when the uterus is coming down and I'm preserving the uterus and reattaching it, and for recurrent prolapses where previous native tissue repair has failed. What the mesh does, it attaches to the strong ligaments. So if this is the scaffolding that's holding the bladder and the ligaments, the mesh goes in and attaches to those ligaments and to the pelvic side wall and gives a nice platform for the bladder and the pelvic organs to rest on. What I use is something called the Axis mesh. We just completed a synthetic mesh study with the FDA, and we may restart that. But at the moment, we're using a biologic mesh called the Axis mesh, which is a human collagen dermis mesh. So this is what's happening, right? The bladder and the vagina has fallen down because of the break in the ligaments and the muscles. So now you go in and put the mesh in, anchor it to the side wall and below it, and you're resuspending it back to where it belongs. If the woman also has occult stress incontinence, like we picked it up during the office visit and during urodynamic testing, then I shall also, to prevent the stress incontinence, put a sling under this urethral tube, and that gets attached to the inside pelvic muscles. The Axis mesh I was talking about, which I'm using at present, is a biologic mesh from human cadavers, and it's a human dermis mesh sterilized to kill any pathogens. The previously used polypropylene mesh is presently not commercially available, but we did complete a human trial, and we may be starting another trial under the guidance of the FDA. So the vaginal approach for prolapse, what I call NINOS, no incision natural orifice surgery, because you're operating right from the vagina without making any outside incisions. There's no need to make an incision on the belly, no need for going from the laparoscope or with a robot. You can do the surgery entirely from the vagina itself, and no incisions on the outside, except a little bit of an episiotomy-like incision for the perineoplasty that we conclude at the end of the prolapse repair. The complications that could happen, such as bleeding, injury to the neighboring organs, or infection, or the exposure of the mesh, are very infrequent. Now, I've modified the technique significantly, and with the present modification that I've been using for the past several years, the risk of these complications are very low. Urinary incontinence, we're very much aware to prevent that from happening, the urine leakage, by putting the sling, but in case it happens, I can still correct it. Sometimes there's difficulty emptying the bladder, but that may be something that was happening from before. Now, immediately after surgery, there may be that you may have to go home with a catheter just for a short period of time. But overall, patients can empty the bladder well. Now, why do you need to do that? Temporary voiding dysfunction. That means after the surgery, we're trying to get the catheter out the next day, but you cannot empty. And the nurse is calling me and saying she's holding back urine. She has like 300 cc's left behind. She peed only about 100. Well, that's because you've got all these IV fluids, and you get a little swelling and pain and the local anesthetic, so the bladder is a little bit numb. It just needs rest. Like how you need a little rest, the bladder needs rest. So what we do, we put in a Foley catheter temporarily. I could teach you straight catheterization, but this is a good option. Just leave the catheter in for a few days. We'll come to the office in a few days, and we can get it taken out. And when you come in and we remove it, most of the patients are successfully emptying. The second thing that you may notice with this procedure is buttock pain and the gluteal pain. And that's because we attach the mesh to the strong ligaments coming from the tailbone. So if you have the tailbone discomfort, remember, apply ice to the butt and to the tailbones immediately, and take the prescribed medications I've given you. Some patients will not take it. They say, I don't want it. They'll fight it. Do not fight pain. Just take that medication, because fighting pain will just get you more anxious and stressed out. And that's not what we want in the postoperative period. Over time, the buttock pain eases away. Pain during intercourse can happen with any surgery, whether you use mesh or no mesh. Any vaginal surgery for prolapse can cause that. It's usually because of a tighter and a different vagina. Like I would tell my patients, you're wearing those old shoes. They felt nice and loose, and now you buy a new pair of shoes which fit you well, but they're new pairs, so they fit snug. So that's why the same thing with this new vagina. It fits a little snug. With regular intercourse, using lubricants, maybe using estrogen and vaginal dilators, this can easily be overcome and managed. Rarely do I have to make an incision to release the vaginal opening. So complications can happen whether you do native tissue repair with your tissue or whether I use a mesh. They can cause scarring and pain at surgery. There's no difference. But the typical thing is the complications in my hands are very low. So our experience with the Access Dermish mesh is that I've been using it now for the past few years, just a couple of years. And before that, I used a synthetic mesh until it was stopped. And I've done about 50 patients. We're following them. So we're about to publish our 6-month results. So our short-term results are very promising. Long-term results are yet awaited, and we will know. So we track all our patients who've had this Access Dermis mesh, and we see how they're doing over time. And we've not had any complications with this dermis mesh, having used in a large number of patients by now. But at the same token, we have to see what the long-term results are. And that's something I cannot tell you what they are. But short-term results are very promising. Now, once you have the surgery, what I was telling you is that you still have to get this muscle built up again. Remember, the water level was way down here. It's very important to do post-operative pelvic muscle therapy. If you don't do this, then you're putting a lot of pressure and strain on the repair. The muscles also have to come in. So the mesh has basically taken the role of the ligaments and a little bit of the muscles, but you really need to get your muscles engaged and do the post-operative physical therapy. So when we make a decision-making analysis, we look at what the patient factors are. That means what is your medical conditions? What are your goals? The prolapse factors, that means how big is this prolapse? Is it the first prolapse? Has it failed before? And my experience, that's all important. So your patient factors depending upon overall health. Smoking increases the risk of failure, so does menopause and a high BMI. And including severe prolapse is a problem because it's a large prolapse. Recurrent prolapse can potentially fail again, and that's where we would do the mesh augmentation. I typically don't do a hysterectomy, leave the uterus in. It's not the uterus's fault that it's coming out. It is a problem with the vaginal tissue strength, and that is what has to be recreated. And ultimately, what we find at surgery, sometimes you open up the vagina and you think that, oh, I can use her own tissues. But when you open up, they're just too weak. So if I just use your weak tissues, it's basically I'm preparing for a failure. And that's not what we do. We want to prepare for success. So then I may put that piece of mesh in between. The surgeon experience is very important. I have been doing this for over 2 decades now, completely from the vagina for managing prolapse. And I do at least about 2 to 3 cases on a weekly basis. And we've had very good success, at the same time, low risk of complications. With the Access mesh, which is a newer mesh that I've been using for the past few years, we're now tracking our data, but our short-term results are very promising. So the management really depends upon how much it's bothering you and how much it's affecting your quality of life. And then the risk-benefit ratio. And as I mentioned, if it is really bothering you, the risk of surgery is very low, and the benefits then would outweigh the risks. So surgery is safe, and over time we'll find is it long-term effective. But when it's done for the right patient by an experienced surgeon and for the right reason, like that's a vaginal bulge, that would be effective. I've given you the post-operative do's and don'ts after the surgery. Please make sure that you read them carefully. They're very well thought out. At the same time, make sure whoever is taking care of you has that. You also have a checklist of what items you should bring before the procedure, like the ice packs, frozen pea bags, Camoseptine, anything to help, like a Desitin to help at the vaginal opening, or Dermoplast spray. Just keep that handy when you come home. And it describes everything. When can you do? How much activity can you do? What do you do in the first week? What do you do in the second week? What do you do in the 4th week? And so on. Bottom line, prolapse is very common. Not only is it common, but the failure rate is higher if it is not properly done, properly thought out. You got to make sure that we plan it correctly. Large prolapses by themselves can cause complications. So it's not that you can just live with this. It's sometimes worse to live with this because, as I showed you, it can damage your kidneys potentially. Treatment options have changed a lot. Now we do this entirely from the vagina, and the recovery is speedy. But for that butt pain, which even gets better if you take the pain medication, your vaginal pain is almost nothing because I do a pudendal nerve block, and I'll show you about that in the next video. But that pudendal nerve block would also help with this nerve at the vaginal opening discomfort. So clearly, a lot has happened and changes have been ongoing. Now, your responsibility is to make sure that besides watching this video, send me the feedback Q&As about this video. Make sure that you get your medical clearance as soon as possible so that we can get you on track for the surgical procedure. Set the time for a preview call with my team, and then we will get you for consultation. We'll set you up for the MyChart and Doxy.me so that we can follow up even virtually. We'll review your feedback, Q&As, and answer any further questions. And I will then reassess everything, your medical history, your medical clearance, and everything at the consultation visit. My promise to you is if you do everything correctly, I can get you back for a consult visit within 1 to 2 weeks of an initial visit. This prolapse has been coming out and it's bothering you. You don't want to live with this anymore, and we will prevent that. I know there are some doctors who do it in 6 weeks, 8 weeks. Well, we have a way to get you in quicker and get this resolved. So there's a lot that you have to understand about this. I went over a lot of information, so maybe digest all this information. Let me know what questions you have through MyChart. And once we see these questions and we have reviewed your diaries and your medical comorbidities and also your medical clearances, then we can properly plan the intervention. Vaginal surgery is now the best way, the most effective way to do it because it's all from inside the vagina. We'll soon find out about the long-term results of the access mesh. Take care.